Everyone, and welcome to the fourth Health for All event, 2 days event, and I'm thrilled to see you all here. My name is Antanas Montvila. I'm a radiologist by training, also working in Kaunas clinics. I'm also Vice President of European Junior Doctors Association, where I'm overseeing digital initiatives in our organization. So I'll be helping and assisting you today through this event. And I'm thrilled to see so many people coming here to face-to-face event and also joining us online to once again learn more about healthcare innovations and trends and to seeing how our healthcare system will be shaping in the future through this exceptional international conference. But I'm also happy to see that you're all interested to learning more from your colleagues, medical students, residents, young researchers and PhD students to what kind of research they are doing in our scientific session. And also we are having a great innovation exhibition where you can not only establish your network with businesses, but also maybe introduce your idea and find partners to build on it. So we will start today's event with our international conference, which is filled with exceptional speakers and international experts, starting from policymakers, lawyers, healthcare professionals and scientists. And today's focus is healthcare data. It's not only learning more about how we can improve and share our health data across the board to deliver care to our primary to our patients, but also to learn more how we can use that data for secondary purposes, meaning like how we can foster innovation and research in Lithuania, but also like in Europe, and maybe finding the ways how we can also try to be leading in this process. But to open the conference, I would like to invite our pro-rector of Lithuanian University of Health Sciences, Professor Vaiva Lesauskaitė. She will be opening the conference and welcome you all. Thanks.
Dear colleagues, dear guests, it is indeed my honor and pleasure to welcome you at this event, the Health for All Conference 2022. I would like to mention that at the Lithuanian University of Health Sciences, we have a long tradition to celebrate World Health Day, which is the 7th of April. And during these days, we are discussing the hot topics of health, which are most important topics. And today, this day is related to the open health data. And of course, this is related to this, that in the 1st July, from the 1st July, will come into the force the law of secondary use of health data. And of course, we all know benefits, and we know this very well-known slogan that data helps save lives. And this emphasize the importance of medical knowledge generated by health data. And of course, if to summarize all benefits as it is helpful for policymakers to make right decisions, it is for the industry to develop health-related products. For the society, for the citizens, it is important because they can get more information about healthcare system, and of course for the academic society, for the scientists, it is a way to generate knowledge that saves lives. However, in spite of all these benefits are and challenges, and these challenges such as necessary resources for the technological shift to open databases. There are also legal considerations and ethical. You know that health issues are very sensitive. And I hope, or maybe I can say, I know that our keynotes presenters, they will navigate us in these lagoons of benefits and indicate rocks of challenges. So I would like once more to welcome you at the conference and to express my gratitude to the organizers which organize such interesting event. And so, good discussions, and I believe that discussions of these results later will become success stories in the future. So, thank you.
Thank you very much, Professor, for this really great insights. And I would like to open our conference and invite the first speaker. We are privileged to have Vice Minister of Health of Lithuania, Aurimas Pečkauskas, who is mostly overseeing the pharmaceutical activities, workforce, medical workforce, information technology, and innovation in Lithuania from Ministry of Health. So his presentation is called, like I would say, like intriguing name, Open Data, one of the strategic goals of Lithuania. So welcome, Aurimas.
Thank you, Antanas. Well, I didn't think that that the name of presentation is so intriguing. I see it more as a statement. But dear colleagues, dear organizers, I'm very happy to stand in front of you. It's always nice to come back to Alma Mater and to see how some events are growing. So especially when you see international conference with scientific session and with a corner of innovation in the corridor, it is really says a lot that we are moving forward, and it's very, very promising. My presentation today is the main goal is to give a perspective of this topic from the Ministry of Health view, and of course this topic is of high significance not only to everyone who plans or are already performing any kind of research activities across the healthcare sector, but also for the innovators, industry representatives, managers, and every one of us who could benefit from widening the horizon of data usage. So, at the present day, I believe the scope of health data has already changed. I hope that we do not only see patient's medical history file as the information only needed for documenting the history or as only a letter to colleague doctor. I want to believe that we understand data like endless useful resource, which improves the economic growth and create a common good through public services and policies. Nowadays, health data stands as a base of pyramid, which leads to creating collective wisdom and is seen as resource which can improve patient care, empower evidence-based decision-making, support innovation, while also protecting patients' personal data, which definitely cannot be forgotten. So what benefits for the public can be brought by open healthcare data? Accountability for healthcare organizations and providers for treatment outcomes, better patients' informed choices among healthcare options available to them, improving the efficiency and cost-effectiveness of healthcare delivery, improving treatment outcomes by opening results of different treatments, in the same manner promoting the transparency of healthcare providers, making institutions more responsive through patients and family education, not to mention economic growth generated by fueling new healthcare companies and initiatives, spurring innovation in the broader economy, and evolving artificial intelligence applicability. But of course, before positioning ourselves as leaders, as it was mentioned, maybe the first slide may suggest that, we must be truthful and consider international context. In the slide, you see our data, which is provided by OECD. Of course, data is not very fresh, it's for 2019. We are looking forward for this to be refreshed. And as we can see, the government, in this index, the government efforts to implement open data policies were measured in 3 domains: openness, usefulness, and reusability. And unfortunately, as you can see, Lithuania was ranked below OECD average and even below our neighboring Estonia and Latvia. And it remains, well, we still hoping that in the updated data chart, which should come out maybe this year or maybe next year, Lithuania will be much higher ranked, and with all the initiatives we can see at the moment, it hopefully will be it. On the more opposite note, in 2021, a European Commission published a report where countries were grouped by open data maturity from beginners to trendsetters. And in this report, Lithuania was assigned to the fast tracker side. So as you can see, we are in the positive side of a slide. And we are together with countries such as Austria, Italy, Slovenia, Netherlands, Cyprus, Denmark, Norway, and Germany. And what a fast tracker means. A fast tracker is the country which shows a good level of maturity against all dimensions. Overall, the country showcases activities to boost data publication with a strategic approach to increase the quality of published data, and a high level of compliance with standards is achieved. The national portal provides a good level of functionalities to cover the needs of advanced and basic users, and limited efforts are made to monitor the impact of open data. Also on the same report, we can see the maybe more eye-friendly slide, and this is the country line with the European average pointed in. And as we can see, Lithuania stands right in the middle. And the good news is that we actually are regarding this measurement quite above the average of European countries. But we still do have a lot of to reach if we want to position ourselves as maybe leaders in using data for innovations. So to talk about Lithuanian context, we need to understand and to mention some of the initiatives which are happening at the moment in Lithuania. So sorry for the small text slide, but I'll try to be very decisive. So for opening the data and for making policy in the data usage, the main ministry in our government is Ministry of Economics and Innovation. And the good news for everyone in this room, I believe, is that a few months back, Lithuanian Digitalization Development Program for 2021 up to 2030s were approved by the government. And in that program, we can clearly see objectives, which is stated as to improve data accessibility and to elaborate on reusing the data, so the secondary usage of data. Another bit that in 2020 there was the portal, the Lithuanian Open Data Portal opened with more than 300 high-quality data sets in machine-readable formats. But to be honest with you, if we look through that portal to the healthcare side, there are quite not so satisfying results in there. We do have the packs of data identified, we can see them, but like real data in there are not there yet. But another bit that Ministry of Economics and Innovation are doing a lot of work to improve that, and actually together with the Ministry of Health, we have already a plan how to open these 70 data sets which have been recognized and prepared as a standard to open up to 2023. So for that reason, Ministry of Economy and Innovation actually had an initiative that every ministry, every other institution in the area should have a special person dedicated to take care of these events. So even in Ministry of Health, we do have a person who is responsible for making these data sets actual and available to public as soon as possible. But it should be open until 2023. So we position our goal in there. Also, the positive note is that in that Lithuanian open data portal, there are a lot of possibilities. So for everyone who comes from the public to comment, to exchange ideas. There are even some enthusiasts who are working with open data to gather enthusiasts to one place and discuss in the meetings through distant meetings to discuss the ideas how opening the data should be improved, could be improved, what can be done in there. Moving forward, so another initiative in another department, the Statistics Department of Lithuania, is actually publishing some data and made quite a few dashboards which are accessible for the public. And we also put it as one of the good examples, maybe how we can use the data to inform the society to move forward in extreme and critical situations. So in this slide, you can see the dashboard, which is published in Statistics Department page, which idea is to analyze COVID statistics. And this dashboard uses GIS technologies and not only to popularize open data, but also to create innovative maps, as we can see in the slide. And the aim is to present the data to the user in a clear, comprehensible, and visual way. So, and as you can see in the slide, there are a variety of topics to choose, so we can have an overview, zones, tests, vaccination, doses, deaths, outbreaks, immunization, and all other bits which are related to data about COVID situation in Lithuania. And recently, actually, since this period is rich with extreme and emergency situations nationwide, the similar approach being taken to deal with flow of refugees from Ukraine war. And truth to be told, it's not only the fancy toys, what you can see in the slide. These data sets are in actual everyday use within all the institutions included when planning healthcare or social services, employment, and other issues which are related to this topic. And of course, it is open to the public. Moving from good examples, of course, we need to touch the e-health system. So another example and first steps being made and the potential place to improve is our central e-health system, which is used to healthcare providers, including pharmacies, to provide patients' health data and for the patients to view his health records. Pharmacies use the system to dispense medicines prescribed electronically. And worth to mention that near 200% of healthcare providers, of course, except odontology, are connected to the central e-health system, and pure 100% of the pharmacies. So there is a list of electronic health forms with patients' health data to be provided mandatory to the central e-health system directly or through integrations with local information systems from the healthcare providers. So already mentioned prescriptions, outpatient visits, inpatient epicrizes, student health certificates, orders for laboratory tests and results, especially the ones related to COVID-19, and some radiology imaging. Talking about radiology, not all the institutions send the data to e-health system, but we working on that and hoping that more and more institutions will send the radiology data also. And one of the ongoing activities in the open data field is to open some parts of the information stored in the central e-health system. And we are starting with the e-prescriptions as the information is well structured and can be anonymized rather easily to ensure personal data protection. Later data of drug-to-drug interactions will follow to be opened. And it is worth to mention that the amount of data mandatory provided to the central e-health system makes only 40% of all the health data stored in healthcare provider systems. Thus, the amount of health data controlled by healthcare providers is larger. However, due to lack of resources, knowledge, and fears to violate personal data protection requirements are not reused or opened in that context. Of course, with a tiny small good examples, there comes a lot of challenges. And as we do have a public narrative about our e-health system that is not working properly, on the other hand, I believe that we must be at least a little bit proud about that system, because we are quite advanced with the idea that we do have this system, although in the going deeper in the structural ideas, there of course are some huge challenges. So if we want to open e-health data in a larger scales, and these challenges remain quite big. And central e-health system and its components are very complex. The main national e-health system manages health records which are integrated with healthcare institutions' information systems, the European Union's data exchange platform, other components of national systems such as SWEDRA, Medicines Information System, and accreditation of professionals and healthcare institution systems, among others. So we do have a lot of integrations with this system, which makes it very hard. Although the data collected in the information system of healthcare institutions are not structured in the same way due to the different information fields, all data are transmitted to our information system in one structure. And the information system used by healthcare institutions are developed by different implementers, and the variety and scope of the services provided also vary. This results in non-uniform level and development of information system functionalities. Healthcare institutions do not share best practices, so that their proven information system solutions are not replicated at the national level. Of course, knowledge, e-skills, and expectations of healthcare professionals and patients about e-health system are very different and fragmented, and it is also being put as a challenge in public to understand the meaning and the need of using data. Of course, the development of electronic information system aims to make them universal and interoperable, enabling the exchange of data. And specific health system standards are recommended for this purpose. Successful implementation of these standards require appropriate experience and development expertise, which is quite difficult to acquire in public sector. And transforming paper-based healthcare to digital also requires separate combined competences from health professionals and IT specialists, not to mention required mentality shift of all the participants who are participating in this field. IT development projects must adapt existing procedures to existing GDPR principles, and this requires a new approach to the existing legislation and requires very timely update of the legislations. Moving from the challenges, so current government will implement the provisions of its program in accordance with the principle of open data, as you can see in the slide. And as one of the main principles of the operation of this government, also digitalization is one of the three main priorities together with the Green Deal and education in the government's program. So there are planned actions to promote opening public data in various areas of public policy, improving the quality of the data and its delivery platforms for the public, the scientific and business communities to use and take advantage of it. Developing and improving technical infrastructure, data management capabilities, and strengthening the need for data-driven management decisions will promote open data use in public institutions for making important decisions and developing public services. So, moving from the open data to the secondary use of data, what was already mentioned in the opening speech by Prorector. So, we are very happy that we actually, a few months ago, moved forward with a law which talks about secondary use of health data, and it's been adopted already. So at the moment, we are working with all the legislation which is under the law, with government decisions and ministry decisions, and the idea to to shared. So the Statistics Department of Lithuania has been authorized as the institution responsible for secondary use of health data, and it's already approved very recently, just a few weeks back. And state health data governance system will be established based on the existing infrastructure of Statistics Department of Lithuania. So the same system I already showed you in previous slides about the COVID data and Ukrainian refugee data. So it is the same platform which will be used for managing secondary use of data. And we do have an advisory group which has been established by Office of the Government of the Republic of Lithuania for implementation of a secondary use of health data regulation. So it is already done. So we are in the process, and hopefully starting July this year, we will have a working process. Of course, we need to understand that when we start any kind of a process, there are quite a few challenges to be adopted, and actually we need to understand that as well. So it won't be working perfectly from the beginning, but we hope it will do its best as possible. So what problems we are solving with this regulation? So this regulation establishes clear rules of a reuse the data and create access to health data, improve the capture and quality of it, and create opportunities for health data linkage. But moving forward, so I think this slide is more self-explanatory, why this approach was chosen, right? And with this new regulation presented amount of data which being kept safely within servers of the institutions, of the other institutions, not accessible, now will be accessible. And the amount of a patient health records, medicine prescriptions, visit descriptions, medical images is huge and is growing in exponential manner. At the same time, we are observing growing demand for this data from medical science, business, government, and other organizations of public interest. And talking about how the process of acquiring secondary data will work in a practical manner. So this information is actually, I think, very important for scientific society, and there will be a single box principle. It means that there will be no need to visit various institutions while trying to figure out and find what you need. Application with identification of data sets needed being submitted to one institution, so already mentioned Department of Statistics, which after reviewing the application grants permission to use the data and over some time gathers all the information needed, and that information is being delivered to the applicant. Of course, we need to understand that health data is sensitive information, and in the mentioned law, there is clearly stated for what purposes this data can be used. So as you can see, it's research and experimental development, innovation, education, knowledge management in the health sector, health policy making, healthcare planning, organization and management, and enhanced statistics. So only these permitted areas will be acceptable. And we do identify that most positive impact from this regulation will be gained by science in opening new horizons for research, businesses by fueling up innovation and fostering better decision-making process, citizens by more transparent and more efficient and safe system performance, and healthcare system itself by data-driven decisions making, powered quality and efficiency of healthcare services. So, and for the conclusion, message to take home. So the importance of data is well understood within the government, and opening it is amongst main goals of a government, as mentioned. But of course, there's always place for improvement. And mechanism creating one box principle, access to healthcare data for stakeholders through secondary use of data are in the final stages. So we are looking forward for summer to come. And thank you for your attention. And in God we trust, but all of us bring data. So thank you. I'm ready for your questions.
Thank you very much, Aurimas, for a great presentation. And We know that Armas will need to leave straight after the presentation because he has some emergencies at work. So if you have any burning questions, he will not be able to participate during our panel discussion. So use the opportunity, and I'll just give you the mic. And
Yeah, hello. I was wondering, you mentioned you have already around 70 data sets available. Do you have any statistics of what kind of data sets there is? Is this only like raw data, like text information, or more complex data, like DICOM images or etc.? Because nowadays it's quite popular to create artificial intelligence-based radiological systems.
Thank you for a question, very good one. Well, I mentioned that we identified what kind of data sets will be open, needs to be open, but we do not have the data itself yet. So we are moving forward to reach that goal, to open that until 2023. Well, I need to double check, I believe, but it is more like statistical data of diseases, of population-based data. We are not talking about medical images to be opened publicly for everyone to catch on.
Okay, thank you.
any more burning questions from the audience? Oh, we have one.
Okay, thank you. So thank you for a very interesting presentation with a lot of information. And my question is such, what is your feeling to wait for the 1st July? What will happen? Have you feeling that all will be done and it will function, or it will take time?
Well, on the 1st of July, I believe we can celebrate a little bit that we reached that date and that the policy is in action, in generally speaking. But if to be honest, as with every other process which needs to be calibrated, needs to be started, I believe there will be some real challenges to managing the situation. So, for example, if applicant comes to the Department of Statistics and requires very specific data which needs to be collected from different institutions, and maybe we do not have guaranteed integrations between these institutions, it might be delays, it might be problems in the process. So I believe that we will experience these kind of situations. And on the same note, I want to ask everyone to be patient and to give some time for Department of Statistics and all of the institutions included to work out the process and to fix it to be perfect.
So we can train the system from the July, yes?
Yes, we can train the system from the July. Thank you.
Are there any questions? Oh, okay, perfect.
So first of all, thank you very much for a very informative presentation, and I would like to congratulate with this great achievement of secondary data use opportunity. So my question is more like technical, operational. So in terms of hospital or healthcare institution infrastructures, are there plans to accelerate competences and capabilities? And do you have like steps? Or maybe some biggest hospitals will start and then regional hospitals will join later, because this is like an infrastructural question is important part of implementation of this big project. Mm-hmm. Thank you.
Thank you for the question. And actually, I do not have a straight answer to that. I really need to double check with people who are directly working with it. So, yeah, I don't really know at the moment. So.
Yeah, and I think we have a last question from the audience, and we'll continue.
Thank you very much. Sigitas Ramanauskas, AstraZeneca. I have a question. Usually when you are starting very difficult and comprehensive systems is very good to test how it's working. And maybe it would be also a good idea to collect some questions from real life, what we could provide probably in order to test, and it will be probably less challenges after the date when it will start.
Mhm. Thank you for a very good proposition. Actually, I think we will consider that, and we will have a discussion with the Department of Statistics regarding this topic. So thank you very much.
And as you all know, we have also online part in this event, and there is a last question from the online participants. I think it's a very broad one. We might keep it like to the even for the panel discussion later on, but maybe have at least few insights. Of the question is, what is open data maturity? So if you have any insights, and it's very philosophical question, I know, but
Well, it is very philosophical. I believe we should leave that for a panel discussion, and you will have more time to discuss in depth about that. So thank you very much.
yeah, thank you very much, Aurimas, and so we are continuing our conference with Jolanta Zaikauskienė. She is the head of medical affairs in Association of Innovative Pharmaceutical Industry, and she is also medical director at ABI, Baltics and Ukraine. She is medical doctor by training, also holds a PhD, and her presentation is called "The Future of Healthcare. Is it all about data?" So let's learn.
Good afternoon, dear participants and dear presenters. So thank you very much, of course, first of all, to organizers of this conference, promoting this topic, and also for opportunity for IFPA, Innovative Pharma Industry Association, to be part of it. So my presentation is really about opportunities, how future of healthcare could be strengthened by using data.
As always, like when the conference is something about digital, this happens.
Murphy law.
Yeah, Murphy law. Perfect.
Okay. So first of all, I wanted to introduce what I'm representing. So I'm representing Innovative Pharma Industry Association, which aligns together 18 companies today. And in the core of our mission is everything what we can do in order to improve access to innovative treatments and promotion of sustainable health system with partnership with all involved stakeholders is also part of our action plan. So healthcare innovation healthcare innovation and progress cannot happen with unlocking potential of health data. And there is emerging demand for unlock health data, driven not only by the need for more personalized health care, but also by epidemiological situation and challenges which health systems in Europe have to overcome. So one of very important challenges, aging challenge. So you see some data here on the slide. So by 2100, the proportion of population aged over 65 years old will increase around 50%. Also, old age dependency ratio is projected to double from 31% to 57% by 2100. It means that only less than 2 people in future will work and contribute to budgets to health care sustainability. And chronic disease challenge is another very important challenge because the total health and economic cost of NCDs in Europe is projected to increase by over than 70% by 2050. Today, almost every third person aged more than 15 years report living with 1 or 2 or more chronic conditions, and 80% of healthcare spending goes on NCDs. European Federation of Pharma Associations issued vision document which is about urgency to power up healthcare system, and to realize healthcare future we must power on over 4 healthcare systems on several competencies: people centricity, outcomes, workflow, force empowerment, efficiency, and resilience. And all this transformation can be braced only with promoting digitalization and innovation, which generates the value for the patients. Profound healthcare transformation will happen in the next decade, reaching mainstream adoption, agility in clinical workflow by virtual artificial intelligence and analytics, automated decision-making, and shifting digital health, merely digital health, to data-driven healthcare, given the fundamental role of healthcare data. On the graph, you can see also very nice illustration where we are now with adoption of healthcare technologies. If we talk about remote monitoring, so currently we are in the stage of late majority are using it. If we talk about algorithms-driven medicine and artificial intelligence enabled diagnosis, so only early minority is using it, and precision medicine, unfortunately, is just started to be used in upcoming years by early adopters, but positive thing is that the peak will be reached in 10 years, which also tells about healthcare, which is saving lives and better health for the entire world citizens. When we talk about data, it's always good to understand because a lot of definitions and big data definition, there are many definitions. I used definition by European Medicine Agency Task Force Group. So big data is extremely large data sets which may be complex, multidimensional, unstructured, heterogeneous, which are accumulating rapidly and which be analyzed computationally to relevant patterns, trends, and associations. And there are different sources of data, including real-world data, everything what comes from healthcare systems, genomics, clinical trials, spontaneous adverse events, reaction reports, social media, and wearable devices. Data is an indispensable part of our life, including health. And currently, healthcare systems in Europe deliver huge amounts of data, which is generated, processed, and stored, but which has to be unlocked for the users in order to provide solutions in healthcare systems. So current situation is that about 80% of health data is unstructured in the systems, and key competencies emerging for unlocking potential of big data. So first of all, infrastructure and technology storing and sharing data. Standardization and structurization is in a scope. Established consistent data entry practices among healthcare practitioners and patients, consumer willingness and to share personal data, trusted setting for sharing this data and for secure access. Appropriate governments also plays a key role on data protection and cybersecurity, optimized secondary use of data, what was mentioned in Vice Minister presentation. So this is very important step forward for enabling health data in medicine progress, and efficient process to analyze and turn high volumes of data into meaningful insights. And last but not least, data-driven physician. When we talk about healthcare ecosystem, so it is very important to have such future ecosystem where data is organized and complete and capture it in appropriate way in order to provide opportunities for advanced analytics. And advanced analytics is a solution for personalized, individualized care and business intelligence insights combining together, which can move forward to digital transformation, enabling smart systems. And data should be collected and accessible anywhere and anytime in healthcare. Artificial intelligence ability to read and analyze quantities of data is key in unlocking full potential of precision medicine. In the table, there are forecast what expectations and what is reality of artificial intelligence in future in terms of precision diagnostics, precision therapeutics, and precision medicine. So in short term, which is 5 years from now, artificial intelligence automates time-consuming and high-volume repetitive tasks, especially with precision imaging. Medium-term goal is that artificial intelligence use multimodal data sets to drive precision medicine and precision therapeutics. And in long term, artificial intelligence enables healthcare system to achieve a state of precision medicine through artificial intelligence, augmented health care, and connected healthcare. Data-driven physician is a consequence of progress in medicine technologies. And opinion of health service providers on opportunities and future progress using health data is very important here. And by the survey done by Stanford University, physicians as well as students and residents believe that personalized medicine will transform due to health data potential unlocking by the most, reaching more than 60%. The next direction is telemedicine, which is also will progress by 52%, and artificial intelligence will play a very important part, reaching more than 42%. For tomorrow, physicians and HCPs, we need also some key competencies. So they have to be prepared to use artificial intelligence and analytics, to be ready to use and shape technology and future development, and have early access to critical health information in order to mitigate poor prognosis and predict the risks. Big step forward is European data health space for unlocking the power of health data. European health data space provides solution how data from all health systems in Europe can be connected to and used for the future progress. So there is set of rules and standards how primary use data and secondary use data can be enabled. So in the scope of this policy and project, there is first of all safe and secure exchange of data, use and reuse, better exchange and access to support healthcare delivery, and so-called primary healthcare, and health research and health policy, making purposes for and enabling use of secondary data. So, and health data is a tremendous asset because it is estimated that the worth of health data reuse can bring value of more than 30 billion annually. And European Federal Pharmaceutical Industry vision is also to transform high-quality data into clinical insights, to build medicine evidence for improved patient outcomes, to using trustworthy and secure digital ecosystem for sustainable healthcare for all citizens in Europe. And our vision is built on 6 objectives, where first is enable innovation ensure stakeholders effectiveness is the second. Third is enable enhance effectiveness. Expectation for disruption, remain focused, remain on patient focused, and healthcare acceleration. Again, some definitions, because big part of medicine evidence is real world data and evidence. And definition of real world data by European FPA, European Federation of Pharmaceutical Industries, which is aligned also with the European Medicine Agency's definition. So it is umbrella term of data regarding effects on the disease, patient characteristic, clinical, economic outcomes, health-related quality of care, health interventions. And also this data should be collected or have been collected through highly controlled randomized, which is not collected in clinical trials, but collected from real practice. And real world evidence created from this data. Not created from this real world evidence, not from conventional randomized clinical trials. What is pharma perspective? Pharma perspective and pharma objective is to enhance engine of data in use of all solutions, because significant shift in healthcare systems from volume-based to value-based drives this necessary need. So, and this engine of analytical models and data, where we have randomized clinical trials, we have medical records, patient reported outcomes, omics, literature, and registries, are used for insights to develop plans for innovation, for product discovery, for new solution discovery. And again, this data, an engine of data, is very important to plan and to inform questions which have to be answered by stakeholders, which are forming policies and providing insights on biological pathways of disease, disease insights, and patient insights. And what are the challenges for using real-world evidence and data? First of all, standards and frameworks are needed to facilitate generation of high-quality data. Data privacy is one of key questions, data access, agreement of appropriate analytical methods, well-defined policies which methods have to be used, acceptance of this real-world evidence data for the use of decision-making also in the center of all initiatives which are currently implemented to make real-world data more powerful, bring innovation, and efficient regulatory pathways that enable optimal use of agency and industry resources. By publication of European Medicine Agency in 2018 and 2019, only 39%, almost 40% of market authorization applications were supported by real-world evidence data, and only 18% of indication expansion indications were submitted, were used also in submissions. Assessment. And what is the future? The future also changes our attitude of medicine agencies, which are responsible for decisions. And currently there are a number of ongoing initiatives which are focusing on developing standards on real-world data and real-world evidence use to facilitate generation and high-quality evidence for healthcare decision-making. So some examples are like European Medicine Agency Regulatory Science Strategy 2025, FDA Real-World Evidence Program, Health Canada initiative, also HMP Real-World Project, and Japan Medical Information Database Network. So current perspective of European agency is to unlock opportunities for real-world evidence data use in also supporting assessment of applications. And there is quite comprehensive plan developed by working group which will be implemented in upcoming years, which consists of 11 areas of different, covering different problems. Public and healthcare partnership also can bring a lot of value in unlocking and using real-world data in promoting healthcare solutions. So EGDEN is a nice initiative, strong initiative, initiated by Innovative Medicine Initiative Group and FPA and European Commission. The initiative is driven to accelerate use of real-world evidence data from different platforms, and objective is to map more than 1 million health data records from different sources, starting different countries, European member sources. You also can see on the left that partner of this initiative also is our neighbor country, Estonia, Tartu University particularly, and using all those data sets from partners, from institutions, there is opportunity to implement observation and medical outcomes partnership, which again will be used for improvement of patient expectation and healthcare outcomes. And EGDEN is governed by GDPR legislation, also collaboration based on mutual need and shared value proposition, and also regional-wide sustainable and local science community meetings are taking in place, and looking forward for the partnership. Very important part of data use is also ensuring data security and privacy, which are key concerns by citizens in Europe. More than 70% still have some concerns, and some great initiatives are going on, and population education is a key. FPA supports also initiative of European Patient Forum and European Institute, which is called Data Save Our Lives. And the aim of this initiative is to improve healthcare literacy among patients and communities through raising awareness of public of the importance of health data, establishing trusted environment for dialogue among multi-stakeholders, promoting responsible use of health data, and facilitating societal understanding and contribution to changed attitudes toward data use. Another initiative, great initiative supported again by innovative industry is Health Outcomes Observatory project, which enables transitioning to outcomes-based system. So in 2022, February, Health Outcomes Observatory Consortium members announced collaboration with Dutch National Healthcare Institute, Danish Medicine Agency, Danish Health Authority, and Aarhus University Hospital to set up pan-European health observatory projects and virtual hub, which collates and share patient-reported outcomes with payers, providers, regulators, and healthcare decision makers. And what is future of healthcare? So first of all, patient-centric and value-driven ecosystem. Future of healthcare is not possible without personalized, connected, and integrated approach. In terms of personalized, we are looking forward for bring change from general to personalized care, patient engagement tailored to individual needs and preferences. When we talk about connected, so it's about possibilities, access to care anytime and anywhere, and remote patient monitoring connects the hospital to home, and patients can easily manage and monitor their own data. And integration is a key in using patient data for precision medicinal care. Holistic view of health and well-being and increased focus on prevention is is a key objective of all health systems in the world. Thank you for attention.
So thank you very much for a great presentation and a chance for us to see how the future will look like and when we'll use more and more of data. I think because of like a bit shortage of time, we have at least maximum one question if there's something from the audience. And if not, we then proceed with every opportunity. There's also a need for regulation. So I would like to invite Andrei Rudanov, who is like expert in medical law. He was working in the field for more than 22 years. He's also a research inventor, and he will give a presentation on how could health data be used, national regulations, and other legal issues.
Good afternoon, dear organizers, dear participants, dear speakers. 11:08. My presentation should be finished after 2 minutes, but I will take it a little bit more. I hope it will be okay. So, the MICE minister today explained about the laws, the regulations, and so on and so forth. And I thought, okay, he's talking about the laws. How can I explain more than vice minister? Let's speak about the practice. Legal practice, real practice in your daily life and in daily life of each clinic, its institution, and so on and so forth. How can we use the health data? Of course, we know that in the beginning was not the word. It was the data. Patient social data. 1992. First patient social data provided in our social tax institution. You know it, Sodra. It's the beginning. And after some time we discuss about it. The next one is patient demographic data. Patient and our demographic register. And only after that, patient clinical data. Patient clinical data first time was used in Lithuania, guess, one. Look, guys, afternoon, not sleeping. When? 1997. First time it will be used in public. And our state institution provide to collect this data and analyze it. In 1999, it was second step. We started the digitalization of data in this sector. The separate health clinics started to create their own programs and system of the patient information. Santaros, Central Clinic, and so on and so forth. But they created their own systems on their own base. We are not talking now about the electronic health system, what we understand as it is functional currently. After that, also we see the system of state patient found, SVEDRA. You know it. I guess you know it. And only in year 20 and I guess so 5, yeah, it was beginning of the health system. Only that. First steps to create this system in Lithuania. All this system currently is acting separately because if we're talking about the healthcare information and data of the patient, we have only information in SVEDRA, information in state patient found register, and this is the data of the healthcare clinics who provide the data based on the state budget. But we have more than 4,000 healthcare clinics, healthcare institutions in the country. And only the half, because only the half has the agreement with the state patient fund. It means that when we are talking about the patient data, we haven't the data of all country in our systems from a legal point of view. Yes, we have in separate clinics this data, exactly. We have some data in e-health system, exactly. We have some data in Svedra, exactly. But if we will ask, look, we need the data of all our country, we haven't such possibility on the legal point of view. How can we use and who can use the information we have now? Patient social and demographic data can be used by population register. It's Ministry of Foreign Affairs and Ministry of Justice. State Patient Fund is a state institution who pays for the healthcare services. Social Taxes Fund, as I mentioned, it's SODRA, and municipalities. Of course, each of us as a patient can apply to municipality or this institution and ask for this data. Also, your attorneys can do that. And the patient organization who represent you also can do that. But in this situation, they have the, some kind of the agreement between you and this organization. Patient clinical data. First of all, of course, it's every clinic the patient visit. This clinic has the part of the patient data, and the part of the data can take from e-health system. Pharmacies, also, state patient fund, insurance companies, and state register. Only the personalized data. And of course, you as the patients. You can use your data, you can apply for this data. You should know that in case you will apply to the clinic or to the state, you can ask for all data, the healthcare institution, and you as a patient, you can ask. All hard copies, digital copies, doesn't matter. And you can ask for, from the beginning you state the treatment till the last prescription or last information, what we have. If we're talking about the availability of healthcare service, you would like to go to the doctor. How can you choose the healthcare institution, the clinic? Where it should be? Vilnius, Kaunas, other towns. How can you choose it? Do you have the information about it as a patient or as a person? No. Do you know the possibility to choose between the state budget payments for the healthcare services and to go into pay it by yourself, just off the pocket? No, because we haven't such system in one pocket, in one hand. And in this situation, our patients can receive the information about the healthcare services only about the part of the services paying by the state patient fund. That's why the availability of healthcare services should be available to the patient, to the association of the patients, and association of the healthcare specialists, doctors, nurses, and so on and so forth. Clinics, because every clinic can apply for the additional services and provide more services for the patient. But they should have the statistics. Ministry of Health, State Patient Fund, and the other institution. Also researchers, universities, state institutions, and so on and so forth. But one thing, how do you imagine availability of healthcare services? What would you like as the patient to know? What kind of information and data you would like to receive? Specialist, clinic, time, and price. It should be paid by the state, or it should be paid by you. All this information should be public, but in this situation, you can receive this information only in that way if the clinic and the state have the general system, and we can monitor all the clinics in all state. Currently, we haven't such situation, and we have such system. Yeah, we're discussing about the secondary health data use and so on and so forth, but we should discuss about the first steps also. And this first steps is not covered. Financing data. Financing data also the part of the healthcare data according to Lithuanian laws, and the patient, the clinic, the pharmacies, pharma companies, Ministry of Health, State Patient Fund, insurance companies, and other organization institutions can receive such information. What does it mean, financing data? It's not the price the patient pay for the services. Financing data, it's the cost of the service. And the prices paid by the state. We're talking about the prices here and the monetary instruments how to pay for one or another service from the state to the patient. And according to our laws, the patient can ask about it and the information should be provided to him in written. It means you can ask about every service, what can you use, and also for the services can apply, for this information can apply university, clinic, pharma company, and so on and so forth. Because this data, according to Lithuanian laws, is public. Healthcare service payment data. This is data about the payment you done to the clinics. And also this is the part of the health data according to Lithuanian laws. What do you think, what institution will be more interesting in this information? Not the insurance. State tax inspection, yeah. Because it's related to the taxes, first of all. And according to our laws, every clinics should provide the information to the patient and should provide the information to the state about the payment was done. In this situation, we are looking, okay, if it's provided to the state, it means that for example, I'm a researcher, okay? I can apply for the state tax inspectorate and ask for the payments done for the, let's say, oncology or diabetes or something like that for the services, additional payments out of pocket paid by patient. But we can receive the answer that there is no information because such information, according to state tax inspection, their legal acts doesn't collect. It means that from the healthcare point of view, this information is out of Ministry of Health, and state tax inspectorate doesn't collect it because it's not the information for their usage because they collect and they account only the taxes. HTE data, Health Technologies Assessment. First of all, Ministry of Health can receive this data and use it. State Patient Fund, State Medicine Control Agency, Association of the Patients and Healthcare Specialists, pharma companies and medical device manufacturers, and other interested institutions. But in this situation, what we have? We can ask about the diseases, about the treatment, about the prices, about the costs, and so on and so forth. But as I mentioned before, the state has only the part of the information what we have in our healthcare system. Lithuanian healthcare system is based on 3 parts: state healthcare institution, municipality healthcare institution, and private. And we have the statistics only about first and second part, not about the third part. It means that if we are talking about the health technology assessment, we can't believe the statistics we receive, just in practice. Epidemiological data. The Vice Minister explained about the COVID situation, but we have such system now. What we have 2 years before? Exactly. And in this situation, the Ministry of Health should receive such data, public health institution also, experts, and our interested persons. But currently, we have only the part of this information, and we can know about only the COVID. Okay, other diseases. Can we take the data right now, real time, today, 22 past 11, and say, okay, look guys, we have the situation with the cardiovascular things. Do we know something about that? The dynamics and so on? No. The other thing is public orders. Clinics, pharmaceuticals, police, Ministry of Internal Affairs, Ministry of Health, and other interested person. We're discussing here about the drugs. Drugs, about the possibility to buy the gun, to drive a car, and so on and so forth. Now you have to collect about 20, 25 different papers and to go to the Ministry of Internal Affairs. If we have the one system, one register, one decision, it can be just join, look through the information, and the decision will be provided after, I don't know, 20, 30 minutes. Why we have such legal situation with our regulations? The Vice Minister explained that we have the laws and the other legal acts. At the base, currently we have our constitution. It's maybe not the object of discussion today. Our laws may just is bound by our parliament, and including law of healthcare system, rulings and decisions of the government, and orders of the Ministry of Health. Other rules, other orders, and so on and so forth. All our electronic system regulation is based on the orders of the Ministry of Health. But according to European regulation and according to our laws, all these regulations about the patient data use, open data use, should be included in the laws. Yeah, we hear today that one of the law is just make it in force, and we are waiting how it works. It's okay. But according to our law of health system, all regulations regarding patient data, collection patient data, providing patient data should be enforced in the law. Not in the order, not in the decision, but in the law. And for example, our colleagues from Denmark use the Lithuanian model created in, I guess so, 10 years ago. Then use the Lithuanian model, and they make the patient register. It's the one system for all healthcare institutions, private and public, and only the information and data provided in such register has a prima facie, prima facie, it means that only this data has the legal right and only this data is correct. Because currently we can have the prescription and the information in clinic healthcare system and database, in electronical and in Svedra. It will be 3 different prescriptions. It's practice, what we have now. If you would like to use the data in practice, you should apply always for several institutions. Ministry of Health, State Patient Fund, register of the state register also, and the statistics. After you receive the answer from these 4 institutions, you need to evaluate it, because sometimes you can receive very different information, not the percentages times. Because sometimes we receive information that State Patient Fund said that we have 25% or 25 patients from the disease, and the statistics provide the information that we have about 124 such patients. It means that if we would like to receive such information, we need to compare it. And all institutions and all the persons, all the organizations mentioned in this presentation has the right to receive the information and patient data. The patient, it means if every patient, you or something else or something one, can receive all data by himself. If it's institution, this institution can receive only the part of information needed for their evaluation. For example, State Tax Inspectorate can ask the clinic provide the information about the visit, just the fact of the visit and the payment, not the clinical information about the patient, what was done for this patient. But if the state patient found asking for that information, they should, a clinic should provide all the data. I guess so. Let's finish.
Thank you for this overview on complexity of the regulation. I guess there are some questions in the audience, or?
I hope so, or no?
No. Let me check, maybe there's someone from the online group. Not yet. So in such case, I think it's like too complex. So maybe we will continue this discussion on this during our panel discussion. Now I would just like to thank you very much for this great overview, and we continue with more international presence. We are welcoming Janek Metsalik from Estonia. He's one of the key architects of Estonian e-health system and currently the lecturer in Tallinn University of Technology. So he's going to present the health data you're used in Estonian digital society. So I'm really glad to see you here. Welcome to our event, and we'll be thrilled to learn more about Estonians' experience.
Thank you very much for the introduction. So today I would like to discuss with you a little bit about health data reuse in Estonia, because we have this like image of digital society. So this data reuse should be easy and natural in this system. So let's just look one scenario from the start. For the start, so there is this scenario that actually our public insurance kind of makes mandatory that children are passing health checks before going to the school. And if we look at these different viewpoints of using this information, then public health research obviously monitors these activities and also the certain health parameters of the population. Then we have a health information system where we manage all the records that all healthcare providers in Estonia collect. And then there is, of course, this reimbursement part where all these activities are then reimbursed or the claims are processed. So I just pick a study from public health side, National Health Development Institute, and they studied the data from different sources of child overweight among 7 years old children. So there is a study of child obesity surveillance, which gives a result of 26% of obesity. But at the same time, if just taking the records from health record system, it shows a different number. And actually, this is just an average difference. If they read the study closely, then they observe pretty interesting differences in different age groups of the children. And in overall, they estimate that only 41% of the 7-year-olds' weight is covered actually by the health record system. And this study also brings out that they have used this documents from the national health records of child growth notification and child examination summary. And these are the numbers of records that they found for the 2020, around 65,000. Is it a big number? Is it a small number? That we need to find out. And the question is also for the studies, why did they only look at this child growth notification documents? Because actually the health record system is collecting lots of different kinds of documents. So maybe this children weight information was recorded in some other documents like outpatient summaries, or so that's the beauty and also the curse of this health record system, which is designed to replicate the document-based health record system, which we have inherited from the pre-digitalization era. And if we look at the insurance information, then we have much bigger numbers of visits for children during this 1 year. And also there are these school nursing services, which also have bigger numbers. So basically here, the question arises how to, which sources of information you can trust and really depend on when you start designing some sophisticated decision support system or some analytical system for decision making. So that's the current angle for the development. But in general, probably you have already been introduced to this Estonian e-health system. So we have constantly collecting lots of documents to national EHR, and it's growing. It's mandatory for all licensed healthcare provider to follow the standard documentation requirements for the national EHR, regardless of whether you are public or private healthcare service provider. So it's really like person-centric approach to this health data collection. And also this is quite well used, this information, so the doctors are querying this data all the time. And we have also cases where when they switch systems or they change places, then they still have access to the patient data that they have collected earlier. So this kind of works nicely, this document-based system. E-prescription is 100% covered digitally. We have also quite strong biobank with lots of gene donors onboarded. E-booking is working national level. We are issuing electronic health certificate directly through EHR, so no papers there. Also, you get, for example, driver license based on this certificate digitally. Also, have implemented clinical decision support at national level. So GPs are having some recommendations and warnings on their desktop based on the records in national EHR. Then there is also this drug interaction decision support system integrated with the e-prescription. So again, like warnings on dangerous cocktails of drugs. And there is e-consultancy between physicians, and also e-ambulance system is integrated to the system. So it's the integration between different institutions. This is what do we know, but we still have kind of question what about the story that I had on the first slide. So let's look. So this e-health system is built on the national e-health national e-government platform. So we have basically just integrating the public institutions and the Ministry of Social Affairs, Ministry of Interior, Ministry of Justice, Ministry of Economic Affairs. They all contribute to the e-health platform, just providing integrated services. Like Ministry of Interior is providing population registry, for example, which is kind of patient registry for Estonian e-health. And then there are public health insurance systems, also some academic systems like this biobank and genome center system, and so on. And then there are private healthcare providers. In Estonia, healthcare service providers are mostly operating on the private enterprise law. And so all these systems of all these institutions are basically integrated through this e-government platform, and it enables to move information around like in a speed of light and in a secure way. And in this regard, this paperless economy works very well. But we still have this question of data reuse, as I'm constantly trying to recall. So let's look another study. A few years ago, we made a study for preparation of personalized medicine decision support. We selected 9 clinical decision support algorithms and started to map them to national EHR. So the idea is basically that if you have the history of patient in EHR, then it should be very easy and natural to just use the data for the automated decision support. So we analyzed the algorithms. We found that there are 6 different categories of parameters. We mapped this to different sections of the documents in EHR, and we understood that we need to query 172 data fields from the documents. And let's take an example. So there was an algorithm that should we increase the use of diuretics with patients we have certain diagnosis and like gaining weight because of the fluid retention in the body. So we got this close to 5-year data set from national EHR and from one of the hospitals in Estonia. And we found that, yes, there are almost 500,000 diagnoses during these 5 years for this heart failure. But at the same time, the event model of national EHR is not allowing to monitor weight gaining. So there is no this kind of information because the document-based EHR is built for summary documents of encounters. So basically, there are no the encounters don't happen so often that you can actually monitor the weight change from EHR. So here we need to change the event model, how the data is shared between systems. Then we can utilize this kind of algorithms. Another thing is that we have the systems kind of still separate, like the e-prescription system is separate from the EHR, and not all the medication data is available in EHR. So many systems need to be integrated in order to even make these algorithms work. So again, a challenge for the information system architects. From the hospital perspective, we can see that yes, it's relatively easy to integrate this kind of decision support with hospital databases because they have more dynamic data set, but still the problem is that the hospital is maintaining only the inpatient cases, and you don't really have like a best person-centric view. So again, kind of failure. So this particular algorithm for this 5-year data set just gave us 0 alerts, which means that this past 5 years, this decision support system would have been useless. No patient would be triggered. No cases would get any warnings. Fortunately, it's not that bad for other algorithms, so it's still a possibility. But based on this observation or this result from the study, we suggested to integrate more systems for the decision support. And currently, this national decision support system is allowing healthcare providers to insert also like operational data directly into this decision making, which is then combined with EHR. But anyway, the question for how to transform from this document-based EHR to more dynamic event-based EHR is still a question that we work here in Estonia. So in order to even further analyze the hotspots or the places where we need to invest more into the developing of the capability of the information sharing, we have adopted the framework which has many different categories of capabilities. So one aspect is technical alignment. So here we look for the interoperability and integration of data. So there are these topics of data quality and data security, transport and interoperability. Then there is more healthcare focused alignment, process alignment, where we look to the composability and information sharing of different actions. So the idea is that you have to cooperate with between institutions in order to make this information flow freely. And here we looked at what is the usability of the systems, alignment of activities, so there is no like duplication and the flow of activities is natural. Then participation, so that like all participants of the activity flow even take part in this information processing, and how is the level of maintaining the consent and privacy of the patients. And it's also combined with governance alignment. So we look at the stakeholder governance aspect, sustainability governance, and data governance of the model. So this capability model is just one of the many capability models. So you can use others, but basically what is our interest was that to understand how this national EHR is used for information sharing, and where we need to focus in the development. So we had chance to utilize this model in Hospital Network Master Plan 2020 project, but there we took like a little bit wider perspective than just clinical usage of data. So we looked at also at if patient has information available for decision making, if managers of service providers have information available for decision making, and also if public health and research can reuse the data that we manage, and also policymakers, and also financing. So we had like this kind of focus group based study where we analyzed the different capabilities from these 6 perspectives. What we found is that we still have this lots of point-to-point agreements of data sharing. For example, this Public Health Institute, they still approach directly to physicians or to healthcare providers to get their information, and there are various reasons. And one was also brought out on this first slide, that they still don't see that the national EHR is providing enough coverage or has enough cases covered. And in some cases also they like to have the data like with like slightly different semantics, and that's actually this biggest challenge for us now is to align this space of information definitions also not just with clinicians but also with public health and other decision making. So currently the national EHR is mostly filled by clinicians and also used by clinicians. And the patient is also having access to it, but contributes very little. Public health research also uses the data in the national EHR, but they are more like observing what is the quality of the data, not so much using it for the real decision making. But the other use of the national EHR is very, very limited. This study also then tried to show which particular aspects of the information sharing need to be addressed. So this is typical 5 or 6 level maturity model. Like the second level is expertise oriented, which means that you are repeating your success. Third level is standards oriented, which means that you have established common base of standards. And then fourth level is already like you focus on performance achievement, and then the fifth level is like the optimal level. So what we observe that we are mostly like moving towards the level 3. So in Estonia, this standardization is really already there. Certain areas see the standards having less value for them than other fields, like clinical is stronger than for example policy. Using data for the policy making, then there they can't really use the data, and they are still on this expertise oriented level. So you have to like hire someone who knows the data and then transforms data for you or collects the data again. So that's the current view. And if we look at the capabilities more closely, then we have this technical process and governance. Then little bit like a controversy here is that actually this respondents of the interviews, they I wouldn't use maybe the word blame, but they see that the technical side is not supporting them so well. They see the problem is in the data quality and data transport, and they want this technical level of the system to support them better. Also, they see that this is a pretty confusing to understand who is owning or controlling certain information and how to get access to this, and also the same who is in which role. So I think, and this is really understandable. We had to address more on making this more clear where is certain data and how to approach it. At the same time, what for me as an IT specialist seems a bigger problem is actually a little bit higher, evaluated by the respondents, that actually they see that systems have like decent usability. From their perspective, the alignment of processes is sometimes okay. They see that they do some duplicate work, but they rather see that the problem is in data quality, not in the alignment of processes. And the workplaces are quite well digitalized. So that's the situation from this maturity model mapping. So just to summarize, I'm bringing here this government e-health strategy, which was aimed to with a real action for 2020 and for the vision for 2025. So it's still valid, and this strategy had certain actions in it. One bigger topic was personalized medicine, and it's still in progress. as I demonstrated from this decision support study, so we still struggle to get the EHR records on this level where actually computers can use it. Currently, it's very good for the human use, but we need to grow further and then make it's computer usable, so we can adopt really fully this decision support and analytics. Then also we constantly work on empowering more this patient or person, and there was also this governance improvement project organized by Ministry of Social Affairs for the stakeholder coordination improvement. Telemedicine was part of the strategy that was introduced 7 years ago, but actually COVID made it. So COVID really introduced lots of telemedicine solutions in Estonia. And we still work on this data quality and open data. Specifically, for example, I'm part of a project which is called Health Sense, where we try to align this process based data model based on the CONSES standard with the messaging dictionary, which is now moving towards HL7 FHIR, which enables more fragmented or more event-based data flow. So this event-based data flow should enable this more like fluid or operational exchange of information. So basically, we see that the technical level of health information exchange should give us feeling that the data is always available. So we don't have to wait for the case close and document submitting and this kind of events. So we have constantly systems synchronized. And at the same time, it makes sense through this continuity of care information standard. And we develop this data model for aligning these processes and technical development of the systems. Okay, that's all from my side. I'm happy to receive any questions.
Thank you very much, Yannick, for such a comprehensive overview of Estonian system. I think it's always nice to see that you always have a clear vision where you're moving to and demonstrating quite, structured approach in terms of digitalization in healthcare. It would be nice if anyone has a question. Just we have one question from the audience.
I can just speak. You can speak into it. One question is about if you were to start implementation right now.
I think it's for the online.
Okay, sure.
Sorry, if you were to start implementation right now of the information system, now having the benefit of a hindsight, what would be the architectural systems or decisions that you may choose to do differently than historically was made in the Estonian healthcare information system?
Mm-hmm. So basically, as I understand the question is, if we would start this EHR development all over, then what we would do differently, yes? I guess we have to do the same learning path once again anyway, because this has been a really good experience. But yes, today, as an information system architect, I really would like to start right from the more fragmented flow of information between systems and not to focus so much on point-to-point document-based thinking between the institutions. But I think the crucial thing also is to introduce the feedback loop into the data quality management right from the beginning. Currently, I think we still miss strong data quality feedback for the EHR. The EHR mostly used by physicians just to see the patient's history, but people are really forgiving about the lack of quality, and this quality analytics should be there as soon as possible. So currently we are looking also for opportunities to build virtual registries on top of EHR, just to enable really faster learning. That's maybe the main point. Just how to make the society to learn faster from these mistakes that we make. Thanks.
Thank you very much for this great insightful answer. Are there any other questions? If not, I think we will proceed because we started a bit later in the morning. So thank you very much, Yannick, for such a great overview. I think it gives us food for thoughts of how we can improve our strategies and usage of healthcare systems. And just to finish our presentations, I would like to invite Grzegorz Kupczuk. He is like Senior Technical Application Specialist in Northeast Europe region at Midray Medical Poland, and he will introduce us on data integration and ER, OR, ICU, CCU connectivity with electronic health records.
Everybody, thank you very much for invitation and possibility to present my vision, our vision about the data integration, about the open data and standards. Let's begin. Okay, one slide about my company. I'm working for Mindray. This is the Chinese company based in Shenzhen, in China, in what we call Silicon Valley in China. What is the most important thing? That we have 8 R&D centers on the 3 continents across the globe, and usually we are delivering 7 to 12 products, completely new products every year. And of course, right now we have over 5,000 patents that are signed. Regarding data integration, because this is the main topic that I would like to share with you. I'm technical person responsible for design, layout, and many times about installation of the quite big IT solutions that we are covering and integrating different data. And what is the most important thing is when somebody asks me about how we will deliver the project, I saw many times during the different talks that everybody are saying, okay, somehow we will deliver, then we configure, and then we install the software, then there will be integration, and in the end of the day, you will have your reports or whatever you want. And I'm a little bit disagree with those kind of statements, because I saw during the last 12 years that those problems are a little bit complicated. So usually on my daily basis, I'm splitting the problem into little chunks. So as you can see here, usually those kind of integration, I split between 2 layers. The first layer on the low, those are the devices. And I'm not talking about only our devices, because usually we deliver some device as a company, but we must integrate with other devices. I will explain it a little bit later. So this is the first level. The second level is what we call distribution layer. So this is important, where our data will be visible, what kind of data will be visible, and of course what type of reports are generated during this work. Of course, this is layer that usually doctors and nurses are working for. And of course, the last one, if it's applicable, of course, depends on the project, is the question, which data and what data we are sending into the upper level systems. So we are talking here about HIS, CIS systems, EMRs, EHRs, if they are applicable, and this kind of stuff. And regarding the lower level, usually we are telling customer that this process is not very simple and not very fast, because we would like to always go side by side from device to device to distinguish which devices we can connect somehow, how we can integrate. We distinguish if they are communicating itself, so if those devices are self-reliant, so if they are capable to send, for example, HL7 or DICOM or any other communication. If not, we are distinguish if they are some internal protocols that we can read and interpret, or we have fully self-reliant devices and then we can connect them. So on this level, we need to distinguish which type of data we are named as quality data, because sometimes hospitals are asking us that only some of the data needs to be sent to the upper level systems, so for example HIS. And at the same time, we are speaking with the personnel, so with the doctors, with the nurses. Sometimes doctors are doing their PhD degrees or some kind of resources, and they are asking us quite often if it's possible to get the very dense quality data. So it means the data that they need to not only the statistical analysis, but to analyze the medical process, medical treatment, and this kind of stuff. For example, analysis of ECG signal, which needs to be extremely dense. So this kind of data are needed. So on this level, we are distinguish those all kind of parameters, and then we describe the plan, how the installation, configuration, and integration with the upper layer systems will be done. Next thing is standards. So we have some standards. Those that you are seeing are not only the one standards that we are using right now, but in general, those are the standards that we are asked about, and of course we are proposed to our customers. And as you can see, mainly regarding the patient health, we are trying across the ER, OR, ICU, CCU departments, we are trying to deliver the HL7 format data. So this is based, text-based communication. In general, it's quite important that to be understand that this is not the protocol of the communication. This is only the standard. So this is the set of some rules how the information should be sent somewhere. The next one is FHIR. It's not the standard. It's not protocol. FHIR, it's more than a framework, how the workflow needs to be correctly configured across the unit, department, or hospital to deliver the good data at the good time. Of course, there is a DICOM. Maybe it's not very common used on those departments, but still it's very, very visible format in hospital. Of course, we have internal protocols, so it means that it's not the device that we are talking about, it's not self-reliant, so we need to somehow grab the data, transform them, and send them through our systems to upper layer systems. And of course, the question is data really open? So, and I think this question needs to be split in two parts, because when we see HL7, it's text-based. So from one side, data is really open because it's open text. It's not secured. It's not pre-shared or crypto or under the crypto protocols. But from the other side, we need to distinguish which data is valid and is quality for hospital, for doctors, for nurses, or even for the stakeholders somewhere in government, in Ministry of Health, and this kind of stuff. So these are the main things that we are focused about, the standards and the data. Regarding the process that we are delivering solution, first I told about the data that we want to know where some things needs to be sent or to which systems we need to send. But this is still half of the story, because when we are going to the department, we would like to always ask doctors, nurses, all personnel, technicians about what's their workflow, the present workflow, because my opinion is not to change the world completely about 180 degrees, but we would like to provide this kind of digital solution that will help and fulfill some needs that personnel have at the moment. So maybe there is a situation that we can only exchange some paper documents to the digital documents, but this is the case, of course, of open speech and open talk with personnel. And of course, across this kind of department, but we can copy this schema and send it to radiology, cardiology, or some other departments, is always where those data needs to be visible and how we will achieve the goal. And of course, to present the end customer the final result, if it's useful for personnel or not. Okay, let's go a little bit deeper with the devices that they are not self-reliant. So we have number of possibilities right now at the moment that if customer is delivering us the list of very old devices, for example, 15 years old anesthesia machines, ventilators, pumps, so we are checking with the producers, manufacturers of those devices, how we can connect them. And at the moment, we can connect this way. Of course, we need some special dedicated devices, cables, etc., but these are strictly technical things. But at the moment, we can support over 100 devices, exactly 146 that right now we are speaking. And of course, our goal is not only integrate, we are delivering the exact list of how many and which parameters we can grab from those machines and send through our systems somewhere up. It's not only the case of parameters, but we are talking here about the waveforms, all the curves, all the alarms. So we have two types of alarms. We have medical and technical alarms. And of course, the benefit for the end users, for doctors, for nurses, is the possibility to see those all kind of data on the one screen with other parameters of our patient. Backward integration, because nobody is talking about this, and sometimes we need to backward integrate our data with some other devices. So for example, we have from time to time some questions about, is it possible to access DICOM data on the OR department? And of course, we can do it at many levels. So we can basically say if you have PACS, probably you have PACS viewer. So we will deliver the, I don't know, medical degree PC, and we put it on some desk and you will have it. But still, this will be another device, another solution. So our way of doing this is to combine those images on our devices. And I think this is the way of the good way of doing this. We are not only one company who is doing this kind of integrations, to be honest. In general, we are installing the separate PC inside our devices, and then we have a number of possibilities how to transfer the layout, the screen of this PC to our devices. Of course, we need support from the personnel, exactly from the IT specialists and technical department specialists, to install the PACS viewer or another viewer that is capable to run it. And of course, DICOM is and radiology images are only the example, because this kind of way we can visualize any HISTs, any other data that can be accessible from separate PC. Okay, let's go to central monitoring, because this is the heart of ER, OR, ICU, CCU departments, and its general central monitoring. We are talking not only about one PC, but we are talking about some solution that is not only distributing but archiving data as well. And this concept is quite important not only for those departments, but from many years it's done already on radiology and cardiology departments, like the PACS systems. What is important here, we would like to deliver the same design solution as other equipment. So if personnel is used to do or used to work on some kind of layout, we would like to interpret and copy this layout into our solution. This will increase the adaptation time, so the time of the learning new solution is extremely decreased. And of course, there are some technical stuff behind it. Of course, we are proposing most of the cases client-server solutions. We think this is the best way right now of doing and managing the data and installing these medical solutions across the hospital. Another thing is, for example, Fusion View. So sometimes we have data in our systems, but what else we can do with them? Sometimes the quality of the data is coming not only from the data itself, but from the possibility how we can treat the data, how we can visualize them, and what type of information our doctors can read from those data. So we are using those kind of fusion views to put at the same time, for example, ultrasound view and live parameters coming from the patients through the patient monitor to distinguish what's going on with our patient. The same process is in nuclear medicine departments, so they are using this kind of technology from many years. Distribution monitoring, during this process we are asking our doctors, our nurses, what are the needs of those people. So where we need to see our patient, we are asking if they want to see all beds, only distinguished patients, only some kind of patients, maybe some other view in the office of the doctor. The same question about what we need to do from those locations. Is it only the view of the patient data, or we need to, for example, manage the device remotely from those places? Those are the basic questions. Of course, above that, we are wondering and asking about reports that they need to be generated in these places. So if it will be PDF report, if it will be XML, Maybe for some statistic analysis, better will be CSV. We would like to have knowledge on this level about this. Next, about distribution monitoring. Sometimes we are sending parameters, and some other companies, HIS, CIS, EHR, EMR companies, do not know how exactly they need to present the data on their inside their software. So for those kind of cases, we are proposing something what is called desktop integration. So we are trying to build in our application inside the HIS or CIS product. And then after clicking the patient and clicking, for example, the parameter data of the patient, some other solution is coming up on the screen, and then we can see the same screen like from the central monitoring station or from DICOM packs and this kind of stuff. Of course, we need to cooperate with HIS vendor. Another thing regarding the medical data is the data that are coming from devices itself. So we are trying to deliver some technical IT dashboards for the personnel who is responsible for managing those devices. And for example, we want to deliver any kind of statistics that they are showing the personnel, for example, IT team, what is the utilization of devices, of some systems, of some PCs across the hospital. Of course, in separate departments, we can generate those kind of statistics. This kind of dashboards have additional advantage because they are managing the central configuration of the devices and firmware version of the devices. For example, we have number of installations that we are delivering 400, 600 monitors at the same time. And after half year, we are releasing new module, new parameter that can be measured from our patient. And the need to deliver this kind of technology is not only some module and some accessories to measure the parameter, but sometimes the need is to make the upgrade software on the devices. So in the old days, we are trying to get with the USB stick and going around the devices. Right now, we are doing this through centralized monitoring, the dashboard. So we are choosing the firmware, the exact software, and we are choosing the scope, the range of the devices, and we just deploy them, and they are automatically installed. The same with the configuration. So if we have 20 monitors on OR departments and 60 on ICU, we can distinguish one configuration, build this configuration on the monitor, and then push it to the other monitors. So we don't need to set up everything on separate monitors. Of course, this is a little bit IT and very strict technical things, so we will a little bit skip, but this is quite important. If it's possible to use redundancy, we are using this. So it means redundancy is the concept that we are doing a copy of the system that it's possible to work if our main system will fail. Medium and large size hospital design. So this kind of reports, this kind of workflows we are doing for our customers, that they see what type of devices will be installed, what will be the workflow that they are using. Of course, integration with HIS, CIS, EMRs. On this level, we are distinguish if the devices can communicate itself, or the communication will be done from the distribution layer or from the dedicated integration interfaces. And regarding integration interfaces, this is quite common for many other vendors. There are situations, very special needs of the customers that report needs to be delivered in some exact way. For example, PDF, very structured. So then if the device cannot send those kind of data on the upper levels, we are using integration interfaces to transform this data and generate the completely new report. And of course, another useful thing is the data aggregation from the devices. So we have only one point that is communicating with HIS, CIS, or other EHR products. And this is all. Thank you very much.
Thank you very much. I think because like we overdone, so we can ask questions during the lunch because we have warm lunch, and I would like to invite you all to have some food. And I just want to inform everyone that we're gonna have a panel discussion where Grzegorz will be also joining us. We will be discussing more about how to use technology within business and research institutions and hospitals. And so we're gonna meet you here at 1, and now let's have a lunch break. Thank you.
Thank you very much.
Thank you very much. all the panel members. Just like to give you a quick reminder on the workshop that's happening from 2 p.m., just one floor up. It's on opening health data, the potential risks, obstacles, and benefits. So I would like to everyone who hasn't registered yet to think about it and just to participate. And today we are going to have a really great panel discussion with the really great speakers. So I would like to introduce them briefly. So I'll start with Sonata Jarmalaitė. She's the Vice Director of National Cancer Institute of Lithuania and also Professor of Genetics of Life Science Center of Vilnius University. So she's extensively working with genetic research translation into cancer, and we're really privileged to have her here because she will be representing both seas, clinical provider, one of the major healthcare institutions in Lithuania, as well as the researcher side. And we also have quite a few representatives from business side, startups. So we have Arnas Karužas. He is a CEO at Ligence. He's also a cardiologist by training, a medical professional. So I think he both have both legs on different sides, because he every day works as a clinician. I think he struggles sometimes with the data interoperability as a healthcare provider. So we hope learn from that, but also great insights from data use, secondary data use for his startup when using artificial intelligence algorithms for echocardiography. We also have Mindaugas Leonavičius. He is currently based in the Netherlands, so we hope to get more like international view on this subject. He is a CEO at a startup called D Health IQ. So he's extensively working with data, the use of data and data analytics. So it's going to be really great to hear the insights he holds. And of course, Grzegorz Kupczak, we already had his great presentation, so I hope he will just be able to elaborate on his previous thoughts. So to start, maybe just a very brief introduction what we aim here. So we would like to have all these people with extensive experience to try to help us to understand about where and how we could move further as a country, from different perspectives, starting from institutional perspective rather than government and national-wide perspective in terms of use of data, adopting the data. And I would like maybe to start from Sonata. Maybe what are your thoughts on how the near future is going to look like if we share more and more of data and we can use it for secondary purposes? So I'm just trying to put us first on more positive note, just to dream a bit, what we can achieve if we collaborate together. Then maybe we will go further down, identifying the obstacles and trying to find the ways how we can all work together.
Now it's okay. Hello, everyone. So I guess you started from the last question about the future, and it was truly very tricky. How do you think, is it medical evolution or evolution? Something about that.
Yeah, we can also.
So when I read the question, okay, it's probably evolution, because we have probably already the third generation of our e-health system. So it's like an evolution. We are learning, we are advancing, and so on. But when we now have so many data, clinical data, we also now mean genetic data as well. So it's huge sequences, a lot of clinical data, including radiology, all those our instruments which can be monitored in activity. So and when we talk about the size of data, it's probably revolution. So we are coming to a nice future, and I like that story about digital twins. It was first invented by NASA and related to space trips and so on. But now we can imagine that even oncology patient can have this digital twin, and we can monitor his personalized health system and prescribe drug in the amounts and to select drug which he needs best of all. And we no more need clinical trials, we need only digital twin.
Oh, that's intriguing. Arnas, maybe you would like to build on the future of, what the future could be, if we would be more able to share it.
Thank you, Antanas, for the question. Yes, I think also it was the last question, but it's a tricky, I think, and it's on your idea to do that. So yes, I agree that the future could be really good, but mainly it depends always on us. And I really like when I'm reading the EU strategy, Lithuanian strategy on the digital health, the future of the digital health, but we always have to ask for ourselves, do we know the steps, what we need to do that we could reach that future and good digital future, and where the data and the health data really could provide us a value. So I think we have all possibilities and all tools to reach that. So we need to look at that, and I think today we will discuss a little bit more about that. So that would be my short introduction about the future.
Okay, it's good.
Yeah.
Okay, perfect. Yeah, it is really nice that we are starting from the end. Regarding the revolution or its evolution, right now I agree that for sure we have evolution, because we all see that data is starting to be initial point to evaluate the patient conditions and predict what we can do else. And of course, oncology is very, very important. I remember that in Poland we start about 10 years ago with analyzing those data. It was not only the medical data, but we start from statistical analysis. Regarding evolution, to be honest, the future will judge if that was the revolution or not. In my opinion, revolution will be when we will be capable to recognize the quality data from the big data sets. This will be the probably the revolution step. And of course, the second thing, because I'm from my by heart, I'm engineer, so I always try to be pragmatic every day of my life. So because we are all the time, I'm asked how much data we can archive, if it will be 5 years, 10 years, 11 years, or something like that. So for me, the most important thing is the balance between how much data we need and how much data can be analyzed with some good results. Because from one side, of course, my greedy nature says that I would like to have everything and accessible all the time, but to be honest, right now it's a little bit impossible to provide those kind of storages for national data. So coming years, and I'm not talking about the Lithuania market, but Lithuania country, but in Poland as well, we are searching some good point where to break those data. So to says that the data from 10 years are enough to predict all the possible options for the patient. Thank you.
Mindaugas?
So thank you for having me here, and I will continue this point of revolution, evolution, and usually if there is evolution, the species who started does not see the result, as far as I'm remember from my school classes. And also I would like to maybe to take into account that we have very good sequence of sitting here, because my product is basically monitoring the patient at home, and not only combining the health data but also lifestyle data, which actually I think it's also a next generation of the treatment itself. What kind of impact you can do on the lifestyle to impact the health status. I think it's also would be impacting the whole process of the medical care, as today we are, most of the focus is on the disease as curing, to cure the disease, and the prevention or personalization is a bit secondary, and this is also embedded in the whole medical process as of today. I think the data and abilities to actually analyze, to find the sequence patterns and about the person itself, you can really have very adaptive treatments, not only in the very high-end disease, maybe as an engineer as well, I will use this term, but also on the chronic disease, which everybody says that it's very much of epidemia right now. So I also, challenging the question about open data, would like to challenge how the whole medical society is really ready to use that data.
I think this is a perfect point that we can come back later on the mindset and the way we deliver care, or whether it's more that we use health data as a tool for us to change the way we practice medicine, or we just want to have data and build everything around the data. So I think we're going to have this part of the discussion in a following question. However, I'd like to, as you all mentioned, some parts of the, even being very positive, some of the challenges mentioned, and we have like this unique setup of people here who works on the research side or in an institution that basically collects a lot of data, and then we have startups who wants to build on that data, or companies that kind of already building bridges within different departments. So what are the key barriers in your institution, in your practice, on broader use of data and elaborating on that? So maybe we can start again from...
I think at this point, the main issue is the quality of data. Because, let's say, our clinicians are only starting to become an extensive users of e-health. We are pressed to do that, but the older generation, they don't like it very much. And I used to see the record of oncology patient, which is in 3 rows, and that's it. But for a qualitative data, for data analysis, we need a lot of information, and it should be in separate rows. And we need to get this IT literacy into the clinics, and probably patients they also need to know, and they need to feel secure by providing their own data for secondary use. So I like this phrase, the trust to the system should evolve, and it should evolve in both parts, from the patient side and from the clinician side. And when we are now users from eHealth, so we only face the challenges, not working again, no data, something disappearing. So the trust is not yet evolved. So from the clinical side, that's an issue.
Yeah, I really very much agree about the quality of data, because looking to our experience building AI algorithms in medicine, it is really what we realized, and of course the science revealed that not the amount of data is the most important thing in creating something accurate, sensitive and specific to detecting something, but the most important part is the quality of data, and it is also associated with all these barriers which we are still dealing in taking the data. And as I am working in all three main platforms as a clinician, as a scientist, because I'm also working in Cardiology Institute, and also as from the business and from the startup. So I saw many of these barriers from all these three perspectives, but mainly what we have to do today, we really have a lot of data. Especially in Lithuania, we really had a platform to have a lot of various data: laboratory, biological data, imaging data, clinical data, which was mentioned also, and which requires a lot of standardization. But talking about, for example, imaging data, genomic data, there are already a lot of standardization, so which we can use, but we need to create a platform where these data packages were put, and where we could use. Of course, the country must research which fields are the most important for country, the most important for science, for industry, where they must focus. Because to do everything at the same time, I think it is not impossible, because it requires a lot and a huge resources to create it. So we must understand which fields, in which fields we must to go, and how we must to prepare that infrastructure for these needs to cover. So, yeah.
Thanks.
We can use this one as well. For me, I see two barriers. One is, of course, I agree that this is quality of data, so it's very hard sometimes to predict which set of data become quality, for example, in 2 years, because right now we do not expect that something will be used. From the other perspective, we don't want to store everything. And of course, the second barrier is connected with budget, unfortunately, with money, because in the end of the day, somebody must decide how much we can spend on storage, how to divide some budget between clinical needs and between technical needs. And yeah, in the end of the day, this is the question of the can we really help a patient or not? Can we predict something from the data? And I think this is the matter of time, because as my colleague are saying today, the AI algorithm, artificial intelligence algorithm are getting maybe more advanced and advanced. So I think in the future, those algorithms can predict for us what will be needed. I hope so. I hope as well it will be not the real artificial intelligence, but maybe more augmented intelligence, because I think we are calling to quite advanced systems with the same name, yeah, but these are little bit difference between them. Thank you.
As we now already sharing our pains, so I will divide them in 3 parts. First is what we're discussing, this R&D phase, where absolutely I fully agree the data quality is absolutely essential. Also the data sets and everything, I think everyone who works in this field knows, how important it is and what the algorithm is capable to do depending on the set and the variety of the data you have. Second part, I would say this is, at the end of the day, we're building what I call decision support systems. Yes, so this decision support goes for the specialists, and we actually have in my practice, which I'm already like 15 years, I see those faces of the doctors or other specialists when data science brings the charge, which she's extremely excited, and then you see those scared eyes of the medical specialist who's really don't know what to do, and there is not decision support, it's actually decision, blurring. And the third part is what impact it does, what those outcomes of the impact does for the patient. I think this is the essential part, and is those can be built in the better diagnostics, interventions, or so on and so forth. Although another part is, which as we today have to touch the legal side of the whole process, I think it's also would be quite a discussion according to today's regulation. The treatments has to pass the clinical validation and so on. If we do have the prediction in the process and the system actually changes medication, assignments, what the process and what the legal things should happen in between if you want to have this automatically without the doctor.
So I think you kind of touching a bit of ethical aspects as well. Do we kind of how responsibility and ethical and legal framework. Before I'm jumping to the next question, I would like to ask anyone from the audience, whenever you have a question, just raise your hand and we'll give you mic to you, because having such collective, of people, it would be way more easier and better maybe, to reflect your questions and your needs. But just to build on the legal aspects you mentioned and having people from different backgrounds, I would like to use an opportunity to ask, how do you would describe and define the current situation with the public-private cooperation in terms of research or even building a business? Because if you build any innovation in healthcare, likely you will need to get public data, you will need to get like patients' data, and or if you like a large institution, a hospital, you will need to provide the data. So do you think that current situation and current Lithuanian regulation is helping you, or is it like one of the bigger obstacles in terms of not reaching that cooperation? I'll just give you the mic.
Maybe it's better to start from the companies. You feel it's more or not. Actually, to be a data provider, of course, it's an issue, and it's not a resolved issue. It's written into the law, but not practiced yet. And of course, we don't have a infrastructure, IT infrastructure, human resources, and so on. So I don't know how it will be implemented, but we are doing some practical work together with the Europe in 1 Million Genome Project. So here we participate all European Union countries in the level of experience. It's so different. So we are now grouped into different experience level, like those who only start at starter phase. So they simply start from the obtaining infrastructure by buying machines for the sequencing, training students to sequence, and only after that we will go to the next phase and we'll start to build minimal data sets to provide to someone and so on. So I think in Lithuania we have truly a law allowing us to provide data, but we not yet have enough infrastructure. So the situation is not very good, but maybe from the, I don't know, so from private sector they can have another view.
So I would like to ask Arnas, because most of the business started in Lithuania. We have other people who working with different countries and markets, you as well. So maybe just also kind of trying to compare what's your insights from our side and what's the best practices available.
Yeah, it's a very good question, and I think yes, we are dealing with a huge lack of enough regulation. We really don't have enough clear regulation on that, how to collaborate the private and public sectors. Even I had a thought that sometimes our company creating some kind of new things, new practice in Lithuania doing that, because a small amount of experience in that, and it creates a lot of issues on that. But today, I think first of all we have to very clear separate the research, the data which we are using for research purposes and for the business development and innovation development in private sector. So because very different rules depend on that, and now we have a practice from our experience with different hospitals, especially talking about Lithuania. In other countries it is a little bit different, because other Western countries like especially UK, Netherlands and Canada, they already have special data sets prepared for data sharing and using for private sector. And in Lithuania, we have to create an agreement or contract where both data providers and recipients have the benefit from it, but this benefit is not very clear how it should rely on agreements and contract, and it is very unclear for that. And also, I think we need very clear guidelines from the data controllers of our national institutions, how we should do that everyone will do it the same way, because I think there are a big variance of how different hospitals, I even could say, starting doing that. So we need a really clear guidance on that.
Thanks.
I think I'm on the best position here answering this question, because of course legislation, law perspective is extremely important, but from my perspective, from my company perspective, we are delivering the devices, medical devices. So we are trying not to affect any law, any restrictions. So we cannot say that this will be useful or this will be not useful for you. We are trying to be as a third part. So we would like to give the opportunity and give all the data to our customers, to somebody who is really keen on what they want to do. They will decide if it's proper or not proper. If somebody says on government level that those kind of data should be, I don't know, forbidden to sharing, we are fine with it. We will only just give the possible options to deliver those data. Regarding other countries, because we are of course looking how things are going, indeed the Western Europe is, I think, a little bit upfront, but still EU is doing a lot of the job for regulatory of the sharing patient data. So of course we are following those rules. If the rules will change, we of course will change our products, our attitude, but still we are delivering only the possible options. The local market needs to define what is needed and what is forbidden.
So just to quickly follow up on your insight, saying that Western countries are a bit more ahead. So could you just provide a few insights? What do you think makes the biggest difference in terms of like our region?
The biggest difference is that, for example, in Europe, the closer UK have the strict procedures and laws. What kind of data can be shared? What is the exact layout of this data? So we are not talking about any kind of data, but for example, some cancer data, there is a exact document that can be fulfilled with some parameters and shared. And of course, they are using those kind of documents, those kind of data through the risk analysis. For example, for cardiology and the oncology things. So this is the main difference. Of course, because it's quite important that the EU legislation was not previously defined by EU, but the origin of the strategy was planned by WHO, so World Health Organization. They created, I think, 12 years ago, some document about patient-centric health management or something like that. It's 160-page document which is describing some, not the golden rules, but some very general options how we can manage the population health.
Yeah, perfect. Thank you for great insights. And maybe Mindaugas will follow up on the private-public cooperation and your insights on the regulatory basis in Netherlands as you are, and maybe broader Europe, and as well in Lithuania if you have some experience here.
Well, working? Hello?
Yeah.
So,
a bit closer,
so from the startup view, I think that any cooperation actually starts with motivation, and in most cases, motivation is also the funding. So for this public-private partnership, I think it's key, especially on new ideas for the startups to engage with universities or academia to have a proper funding from the grants, or it should be also on the academia side. What I'm facing now in Leiden, for example, where they have certain programs already for that cooperation. From the regulatory perspective, I think we have this, if you are going to develop innovation in the health and you have a patient data, or actually connecting your developments with the patients, you have to have passed certain procedures, accreditation or bioethic permissions. So for us in Lithuania, as I experience, is centralized. It takes quite some time. In some cases, in Netherlands, there is more like institution-based, and Leiden University has their own bioethic permission committees, which goes much faster. So that's one thing which actually also helps quite a lot, and also resonates on the cost level of any initiative. Secondary, as I mentioned, this is very important, how they designed this partnership. For example, we're now participating in incubation acceleration program in Leiden, so they have an approach that most of the PhDs actually, especially who does the quite impactful research, they actually motivated to go on the startup, to push your technology, push your invention. We're participating in biotech accelerator, so most of the PhDs actually forming the groups to go ahead. And does not matter where you end up, at least you're building certain also experience with academia, with hospital and the business to accelerate the idea into the commercialization.
Yeah, it's a really interesting approach to have, I think. Just focus more on translation rather than publication. But we also have a question. I'm really happy to see, and I'll just give you my consent.
Hi, thanks. Yeah, so we are talking today about the gathering the data from healthcare sector, let's say, and providing all those solutions. I was wondering how Lithuanian doctors or healthcare system in general are open for those new solutions, because we have this kind of stigma that maybe Lithuanian doctors are not as well IT educated as Western countries, let's say. So we are coming up with those new solutions, for healthcare sector, and I'm just interested, how is it easily implemented in like daily work for doctors or so?
Anyone from the panel can start. Who has their insight? Just until they kind of decides who. I just want to build on that a bit from my personal experience. So, seeing European countries, because working in my association with European junior doctors, I also bring that mindset from Lithuania. We always think that, oh, we are lacking behind all the time. However, like this is the current problem, I would say, like in major countries, and we still not have like proper, not even like digital literacy programs, but like I think this also requires a bigger mindset change. So we would like to add on your kind of skill set thing to the questions, like the other layer would be, additional layer, also the mindset. Do you see any chances or ways how we can also change the way doctors think about healthcare? As mentioned here, from direct care provision to more like preventative care as well, because the data is for that, I think.
Maybe I will start from the simple things, how our doctors are willing or not to use e-health and so on. So actually, sometimes bad things turn into a good thing, and I mean pandemics. So telemedicine, e-health, with this communication from this distance, it so improved through the pandemic, and actually we started like with the willingness to use telemedicine and e-health like for about 10-15%, and now it grown, and I think the doctors who are not very willing to use e-health or other IT solutions, they are left in minorities, because everyone got the use of and benefits from that. And actually, telemedicine is a very good thing even for our country, and we are thinking when we have only 6 oncology hospitals in our country, but the patients, they need consultations in every city of Lithuania, so teleconsultations, then it can be multidisciplinary meetings, especially molecular tumor boards, which is innovation in our country. Then we can have only one, but it can be used by telemedicine. So everything improving, and doctors, they are very clever in that.
Yeah, it's a really good question, and I think this question has a little bit different approach on general question how doctors are in generally open for all innovation, not only just using digital health system. For me, I think, and looking in different age and different experience of doctors, I think it is not so hard to learn how to use it. Of course, one doctor's preparing for that faster, someone a little bit slower, but our system in general is very fast. So I think all doctors are forced, especially in COVID-19 situation, really all we're forced to get familiar with that digital system. But the question is about how the system, the doctors are open for all innovations coming, and it is a really huge issue, I think, still in all the world, and more and a bigger issue in Europe compared especially with the USA. And we can see and we must understand that medicine as a system is very conservative, and it's always during all the evolution of medicine this very conservative system, and all innovations coming very slowly. Of course, it is depends on that we need a lot of regulation procedures and etc. It's okay because we need to create a safe system for the patients. But the mindsets also are very slow. And talking about the willingness to use innovations, in our practice we saw also quite a huge difference. The same examples, UK, Netherlands, and for example, Baltic countries. it's a very huge difference when you give for the physician, for example, Netherlands, to try a demo version and how fast he or she becomes familiar with that system. And it's a huge difference with our countries. But it's understandable because we are living in a different systems and especially different health systems, despite of our general digitalization, which Lithuania has a really quite good level. So yes, we are dealing with that, but I think we are really moving forward fast with that.
Regarding the things that we are doing and following the question, because we run a number of projects across the region, it's not only the Baltic countries, and I would not say that there is a big gap in the knowledge or this kind of stuff. We see that there is, for example, barriers when we are delivering some new functionality or new solution. So we distinguish that we have some groups of doctors, of personnel, that some of them are very open and some of them are not so many open. So in my opinion, this is not the gap of the knowledge. Maybe this is the case of mindset. So the question is how to change the mindset of those people. But of course, it's not the case to be a slave of the new device or new functionality. So for us, for everybody, not only the vendors on the market, but everybody who touch the healthcare system, is to all the time educate the people what are the benefits and what are the outcomes from the technology. Because still, as we are sitting here, we are delivering some value to the markets and on different levels, in clinical values, some technology values. So this is the case. How we can convince them that this is important for their lives. Yeah.
So I would step on the doctor side now, even I'm a mathematician. First of all, I was before I start 5 years now in the health, was in a different industry, banking, accounting, etc. And everywhere we were talking about AI, machine learning, and etc. We think this is the very close community. This is very conservative. So it's not only doctors who is conservative. Rest of the world is conservative as well when it comes to this topic. So that's one. Second, honestly, we also were facing the situation where in innovation development, when you engage with the doctors, they by default very empathic persons, and they want to help for the patient. So everything what you bring new, it's excited. Maybe I just was working with those who's really pioneers, and they see the future in the product. But when you're coming already to the hospital, or especially now we're facing with GP, those doctors are really overloaded, and additional for us, which we lived with this product for 3 years, for us it's a baby, we really like it, we know every button. For the doctor is another hell, which he has 3 systems already he has to work, and suddenly another one which pops up, and I don't see the excitement in their face, even if they want to help for the patient in that way. So I think it's also on our side that, first of all, if I was sitting in a car and suddenly I got into the jet, I have zillion of the buttons, I would not like it, and that's what we have to also to consider when we're developing technology, that it would be also intuitive, adaptive, and not overloading, but helping their lives.
Thanks for the great insights. And just to remind everyone, we also have participants online, and we have a question from the online audience. So just a brief question, a question for all panelists. What role do you think there is for higher education institutions, such as medical schools, in the sense of development and improvement of health data collection analysis? Can you just provide brief insights on this question before we go to the closing remarks?
So yes, it's truly we need to change a little bit our education, and medical students now need to know a lot of molecular biology, IT, whatever, and then again got into this overloading and so on. Probably we need to specialize a little bit more, and actually National Cancer Institute, we, 60 specialties, and medical physicists, medical biologists, medical geneticists. So we need medical IT specialists or something like that, not to overload our clinicians. They need to take care about the patient.
So you think we should kind of develop another profession that works hand by clinicians who deliver care and help assist them with understanding technology and building more, or should we kind of integrate more?
Some basics, of course, they are needed. They are needed in daily work, but to prepare good quality data sets, we need specialists in the clinics. That's for sure.
Yeah, it's a very good question, and I think we also need a much more higher number of data scientists, because they are mostly specialized to work with the data, and of course with various data. Yes, I fully agree that in high schools, and especially talking about medical schools, we need to pay much more attention on how to prepare students to use and to analyze health data. But I think as looking to the EU strategy and how data should like, so the most important thing that we will have the place where we will have the possibility to take fast, easy, accessible, and etc. the data, because taking the data is not the most hardest place it should be. The hardest place is to prepare these data sets that would be accessible, interoperable, and etc. So if we have that, we will solve the biggest part of the problem. But yes, of course, the medical students have to have much more, a bigger package of basic knowledge of data science, especially medical data management, and in general in Lithuania and in education, and especially in technology type universities, we need much more, a higher amount of data scientists which could collaborate and work together with medical scientists and clinicians.
Yeah, from my opinion, this is true that maybe more attention should be forced onto university, especially university education regarding data. But to be honest, in the details, how much universities should train or teach regarding data, this is another, I think, topic. So in the basic range of specialty, we should provide sufficient knowledge about data, about how to prepare some basic sets. Maybe not the standardization of the data, because this is the case for data scientists. So the question will be if soon, in some soon future, there will be new education level, like clinical data analyst or clinical data scientist who will standardize the data and have the at the same time have some clinical knowledge about how to distinguish which data needs to be chosen to those data sets. Yeah.
I think we started talking about evolution, and I think when the radiology was invented, when we defined the gamma waves, certainly the radiology appeared, yes, as a different discipline. as a type of specialist. I think evolutionally we also going to have such a dedicated specialization, and right now in our product we even have such a role, what we call a data nurse. This is the specialist. Right now I'm converting mathematicians more in the health and they becoming a data nurse, but this capability to actually interpret and prepare the data for the specialist to make the decision. So it's naturally the data itself, or it's not a goal. I think this is the goal, what you can do in diagnostics, in treatment, in interventions, and that definitely will appear certain specializations in this process.
So thank you very much for the great insights and answer to this question. I think we have like only a few minutes left for this wonderful panel discussion. I would like to have you for more than an hour, but we have a workshop, so I'll just ask you for a very brief recap, like what you think are the key things to address for us to better integrate data, to better use data, to achieve that future, as we discussed in the very beginning, that bright future we all agreed is upon us. So how we can achieve your bullet points of like key insights, because I cannot not use your insights and expertise in this. So, yeah.
Okay. Thank you for this. So to conclude, I want to thank for this discussion and for all this meeting, because we discussed 2 years and now we have a law, and now we started to think how to implement it. So it's a first thing, it's a first step that we started to speak. The people who will probably will generate the data, will use the data. So I think it's very useful discussion. And regarding the future and what data sets we need, so I only can to repeat it should be we need to take care about the quality of data, because the amount, size, it can be created, but it should be useful for the patient. Thank you.
Thank you very much. Thank you very much also for all the panelists, for the moderator. And I think, yes, it is, I was very surprised when I get the invitation to discuss about data, the health data. I was thinking, oh, what do I need to speak in health data? Okay, data, yeah, it's okay, it's fine to have data. But yes, but it's very important and very nice that we are discussing about, because we are moving on that, and it is a very good sign that we are moving on that we are trying to empower our data to create a value for us. I think it is first and one of the most important mindset for all of us, for stakeholders, for the politician to understand that we have a lot of resources. Yes, we're always discussing and think that we don't have gas, oil, or something, but we have a lot of data which can create a huge value. And even the budget shouldn't be an issue to use it, because it can create a huge amount, a huge budget, and a huge values for the country itself. So I think we should move together with the youth strategy. We have a start, and as I think today Vice Minister of Health Ministry presented today, we have a start in preparing and using secondary health data. So I think we should move forward. We should move forward connecting industry, academia, and clinicians to create the best approach for all of us.
Yeah, regarding the technology, I think some main bullet points is that we have sufficient technology to provide good data. Yeah, this is one bullet point. Second bullet point, we need somebody or something or some algorithm or solutions to distinguish the quality of data. This is the second point. And third point is that we need the people who can use those quality data and to predict what we what is really important, because above all, we are, of course, today we are talking about the data interconnections, but above all, there is patient health, and this should be the main target. And of course, another things is to how to change the mindset and attitude of the people. So I think if we change the mindset and we will try to change attitude, the rest of the problems like legislation, not enough budgets or something like that will be not the big problems, to be honest.
So I will probably continue with the first, saying that in the whole process there is most important how clean and how good is the data, and that probably if we will have such a target, then the rest will follow. And maybe as a last point, I'm really looking forward to this interoperability, not only on the data level, but on all specialists, doctors, engineers, and users level, the patient.
So thank you very much for really great insights, and thank you all for coming and trying to better understand the complexity of health data. And just like to build on the idea that Arnas told, that there are people who says that data is the new oil. In my opinion, is the new soil. So this is on how we're gonna use it and how we're gonna nourish this great resource, and how we're gonna develop the better healthcare and together. So thank you very much for the insights, and thank you very much for all of you coming, and again, inviting you all to the workshop that's happening in 1 minute. And but you can grab a coffee, and maybe they will, give you those extra 5-10 minutes to. And so, thank you very much again, and I hope to continue talking on this topic.